All right, everybody, we'll go ahead and get started. Sorry for the late start. For those of you who might join in, busy day at the office this afternoon. So tonight's chapter is going to be on pediatrics. A lot of the same things apply. So similar to when we talked about medical emergencies. It'll be kind of in the same format. We're going to run through several different types of medical emergencies, but just for pediatrics. And really, like I said, a lot of the same things generally apply. A lot of the same signs and symptoms, but we're going to talk about little nuances for children and infants and things like that. So it's just again one of those things where we have to kind of pay attention to the little things when it comes to kids, no pun intended. It's just they have little quirks and stuff that we have to be aware of when we're dealing with kids. So sudden illness and medical emergencies are common in children and infants, just because their nature, their judgment's not that great usually. They especially in little kids, much smaller children, toddlers, things like that. They're prone to falling down and having, putting things in their mouth and, touching hot things and all sorts of stuff like that. So, it's one of those things where we have to, constantly be aware of what they're doing. The other thing is anatomical differences exist between children and adults. Their airway is smaller. Some of their developmental, some of their issues with their body just aren't developed like we are. So they're more susceptible to breaks and injury and things of that nature. And like I said before, respiratory care, respiratory care is very important for pediatrics. Like I mentioned, their airway is smaller, more susceptible to choking or to occlusion. So it's definitely something we always have to be considerate of. Generally, and again, over the years, I've seen emergency personnel of every type, veteran paramedics, cops, firefighters, doctors, nurses, do some really heroic things, but also I've seen people do some really dumb things, risking their personal safety and things like that to provide care for a child or responding to an incident involving a child. So, like I said, some very heroic, some just really really unsafe and things like that. So, you really have to try to remain calm and professional. Especially those of you who have children. A lot of times it hits home and sometimes makes it harder. Like I said, I've seen veteran paramedics get stopped right in their tracks, not be able to provide patient care because the child resembled one of their children, or was the same age as their child or something like that. And, or that was, went to school with their child or something along those lines. And they were rendered, inoperable because they just couldn't keep going. They had to have somebody else come, step up and help them with patient care. So again, take a minute and remember that, it's a patient just like anything else. And we understand that they're, sweet, innocent kids and all that. And we, we respect that. But at the same time, they're a patient just like if they were 95 years old. Okay. We have to, try to treat them as we would anybody else. And usually if you do that, usually you're going to be just fine. So, as far as parents go, sometimes they're all about it, all about you helping them. They'll just surrender the child to you and whatever you say goes. But sometimes as well, they are your worst enemy. They don't want to let you do anything. They don't want to let you have any say so in what happens to the child. They don't want to take any of your advice, anything. So, you really almost have to treat them as well as treating the child sometimes. So creating that rapport with them, talking to them as well, keeping them informed as to what your patient assessment is revealing and what your plan is for the child. Then that's a big help, in most cases. So. With the children as well, like I mentioned this before too, it's good to get down at their level, kneel down, squat down, whatever you got to do. Sometimes sitting on the floor, whatever, depending on where they're at. If we can't pick them up, things like that are going to just kind of help you, seem less of a threat to them. With especially, toddlers or a little bit older and up in the pediatric chain there, it's good to keep your stuff simple. We don't want to we really just want to kind of get the main facts from them, and a lot of those questions are, we can help to kind of localize where maybe pain is or how they feel or something like that if they can give that information to us. But we may have to ask it in a certain way, in a childlike way, that they understand. We also may need to do some of those things more so to get an understanding of where the level of consciousness is, right? So if they are normally, talkative, playful, that sort of thing, and their arm is broken or something, and now, or they hit their head or something like that, and they may have a decreased level of consciousness, or they're acting strange. That may be something where we start to see those changes happen is during that question and answer phase. But irregardless, try to keep it simple and to the point. And sometimes it helps just asking about their favorite thing or what they like to play with, or whatever, little things like that, just to kind of gauge their ability to answer questions. Be honest with the child. Kids are smart, right? So kids usually don't have a filter. So they'll ask you, like, "Am I gonna die?" Or "Is my mommy gonna die?" Or what's So they'll ask you straight up. Like, "Is my arm? Am I gonna be able to keep my arm?" Or whatever. And so you kind of have to, same thing, be simplistic and direct, but we don't want to lie to them. So if we can kind of do a workaround where we're not lying to them, but we're also not necessarily giving them all the information, that's probably beneficial for them. Like I said, depends on the age of the kid. What their kind of what their level of understanding is. Toys, teddy bears, stuffed animals in general, those types of things are cool. For a long time, we take a clean exam glove, blow it up, tie a knot in it, and draw a little face on it with like a big nose for where the thumb goes, and it sounds like a little chicken mohawk kind of thing. And we can make little funny faces on it or something like that with our pen. I mean, that's something that we've done for years and years and years, and it's just for little bitty kids, it's something funny and playful, and they can squish it, and it's almost like a little stress ball for them. A little bit up from that, that range of children, may like teddy bears or soft, cuddly things or whatever. So, but you get on up into 7, 8 years old, you hand them a teddy bear, they're going to look at you like you're crazy. So, maybe a little toy car or something along those lines might be more apt for them to get excited over. So, anatomy and function, again, some differences there is the child airway is, like I said, is small in relation to the rest of the body compared to adult's airway, and the child's tongue is proportionally larger than an adult. So their tongue is just larger, as far as in relation to an adult's airway, the child could choke on their tongue more readily than say an adult would. The upper airway of a child is more flexible than an adult. For at least the first 6 months of their lives, infants can breathe only through their noses. So when the demands on the child's respiratory system change, the child is able to quickly compensate by increasing breathing effort. So if you see them breathing through, little babies breathing through their nose rapidly, that's probably why. So limited abilities to compensate for changes in temperature as compared to adults. So generally they don't have the fat stores, they don't have basically the insulation that we do. So and just in general, they don't know how to deal with that. So the body ends up, obviously keeping them in that state for a little bit longer. And so, if they do have, major changes, then they're just not going to be able to compensate for that as quickly as we would. So big thing, keep them warm, right? Keep them comfortable. We talked a little bit about that with our newborns the other night. So same thing, we're going to keep them warm, right? So patient assessment for a child, it's, again, infants and toddlers who can't speak, and it's challenging. There's no doubt about it. Okay. However, you have to, it's kind of like evaluating somebody who is unconscious, like an unconscious adult. We can't ask them any questions because they're just going to babble at you, right? So it's really not a whole lot of use really trying to ask them questions, but up to a certain age. But if so for those patients, we have to be creative, but nonetheless, we're still going to do that assessment. And, I may not be able to ask the patient, but of course, if there's caregivers or parents or something along those lines, then we can try to fill in the blanks. But again, nonetheless, we walk up, the patient is crying. We know that if the baby's crying, then it has a open airway, it's breathing, it has a pulse. Hey, we knocked out 3 or 4 things right there, right? So that's little things like that are apply the same way as it would, if you walked up on an adult. So, moving the arms and legs around, moving the head around, trying to crawl, trying to walk, things along those lines help us to realize that, more than likely they have a certain level of mental capability, right? So they are, they're with it to some degree. They're able to move their arms and legs, things, their neurological system is to some degree intact. And so we can start building off of that, right? It doesn't take long to see those things. So if we're starting to check a lot of boxes just by looking at our patient. And so, like I said, for some of these younger patients, that's what we're going to have to do. Nonetheless, we're perform that scene size up, make sure the scene's safe. Again, get that into your head over and over and over again. That's the first thing. Scene safety. Complete a primary survey. Like I said, talking to, a conjunction of talking to the parents and also examining the child, and then complete that secondary assessment by examining the child from head to toe, just, depending on what the issue is. If it's medical in nature, nonetheless, we're still looking for, different types of signs and symptoms that we'll cover later on in class. But it's, we're looking for those outwardly signs that we can see and any other symptoms that they may be presenting. And then from there, we'll, if it's a trauma patient, we're doing our DCAT BTLS, looking just like we would for an adult. You try to get that medical history, especially, children go to the doctor a lot, right? So especially early on in their life, they're at the pediatrician or the doctor's office or the ER quite often for different reasons. So anything major that might, aggravate whatever it is going on now, we need to know those things. And of course, we're going to perform those reassessments as we need to. The Pediatric Assessment Triangle is just one version. There's several different ways of pediatric assessments out there, but essentially helps you quickly form a general impression of the child using only your senses of sight and hearing. So really, realistically, is a lot of what we've just been talking about, and it can be used to assess a child from a distance. So, like I said, if you have a screaming child and you can't get anything out of them, they're just inconsolable. Again, we're going to get some of the major things out of the way. We're going to get our ABCs out of the way, and then we can start to build on it from there. But it's an indicator, their appearance is an indicator of how well the heart, lungs, and central nervous system are working. Compare the child's appearance with what you would expect from a healthy child. Assess their eye contact, muscle tone, and skin color. If we call them by their name, hey mom, what's his name? Oh, his name's Johnny. Okay, hey Johnny, and Johnny is 3 or whatever, and he turns and looks at you. Okay, then more than likely there is some level of cognitivity there that that we can apply to that assessment. So again, reassess regularly because the appearance can change quickly, and we'll get into why that is in a second. So again, looking at the characteristics of appearance in this table here, you can see movement, interaction, reassurance, eye movement, speech, and cry are the characteristics. And again, healthy reactions and unhealthy reactions are on the right. And so, you can kind of tell when they're not acting right. Just as a general rule, they're doing things that normal children probably would. And, if they're staring off into space, most kids don't do that. They're constantly looking around, trying to look at, moving and shaking, right? If they are able to speak and they have confused speech, garbled speech, they're not making any sense. Whereas you ask the parents and they're normally, oh yeah, he knows his ABCs and he knows his 1, 2, 3s and he can talk and all this other stuff. And you go, okay, well that's different than he's obviously not speaking correctly. So little things like that will help you to kind of indicate that something's not right. The characteristics of breathing, remember, children breathe a little bit faster than we do naturally. So again, the more accurate indicator of a child's condition than merely determining the respiratory rate. The abnormal breath sounds, again, noisy, wheezy, that sort of thing. Abnormal positioning, leaning forward while using the arms for support. So if they're trying to lean forward and you notice them having difficulty breathing, retractions, the collarbone and between the ribs, whenever they breathe, they'll have some of that space in there will actually kind of start to pull in a little bit, and you'll notice almost like they're breathing through their ribs. And then flaring of the nostrils, like I said before, they're trying to get as much oxygen as they can, and so some of that is them again breathing through their nostrils more so than their mouth. Skin color or characteristics of circulation to the skin. The skin color is one of those key things that we look for. White or pale skin or mucous membranes, as far as it's called parlor. And mottling is the patchy skin discoloration caused by too much or too little blood flow to the skin. So again, if you have that decreased blood flow, you may start to see that. And then cyanosis is that blue discoloration of the skin and the mucous membrane. So around the lips, hands, that sort of stuff. We start to see those things. It's usually that the body is not perfusing very well. It's not getting blood flow, not getting oxygenated blood to where it needs to go. So same thing, count respirations for 30 seconds and multiply by 2. Look for signs of distress. And, when we do that, we want to see how hard it is for them to breathe. And that's, just one of those things that we can try to see if they're in some type of distress. Look for abnormal breath sounds such as noisy breathing, like we mentioned before, snoring, crowing, grunting, wheezing. If they're really kind of focusing, they're not looking around doing all this other sort of stuff. They're really kind of focusing on their breathing and their positioning. Then that's more than likely you're going to have some type of respiratory issue, which is common in children. Okay, we see that a lot. So they have some mucus buildup they can't get out, especially when they're real little. They weren't burped well enough, aspirating on something, have something in their airway, right? So there's a lot of stuff that hurts children or is airway related. So determine whether the child is holding himself or herself in an abnormal position. Check for those retractions and look for those nasal flaring. Again, pulse rates are faster, especially for infants, but also as we get up into about 1 year of age. And when we check for those pulses, remember we're going to check in the brachial artery, right there in the upper arm, on the inside of the upper arm. So again, things to remember, if you don't already have this, or you highlight it in your book. If you don't have a book, and you take a picture of this and remember these. Your normal vital signs for children at rest, so children just under normal activity. Your heart rate for newborns, 90 to 180. Infants, 100 to 160. Toddlers, which is 1 to 3 years old, 90 to 150. Preschool age, 3 to 6 years old, 80 to 140. School age, 6 to 12 years old, 70 to 120. And then adolescents, which is your essentially almost adult, 60 to 100, is your heart rate ranges. Okay, so anywhere from 90 to 100. 180 to 60 is kind of what we're looking at there as we go on up in age. But so for newborns, again, very fast heart rate, and infants same way, very fast heart rate, and then we start to see it come down a little bit, toddlers and preschool age. So respirations on the other side of that, like we've been talking about respirations. So if you have a child, if you have a newborn or an infant who is, up in the 50s, 60s, we're starting to get to a pretty high respiratory rate for them. As you look down to adolescents or adults, it's 12 to 20 breaths per minute. So that's a pretty big difference. And so as you can tell, as we start to get into the mid-range there between 1 and 6 years old, it's somewhere between the 20 and 30 range. But again, as we get older, it starts to come down a little bit. We start to breathe a little bit slower. Body temperature is another one that we run into a lot, especially with infants and toddlers, is fevers. It can have a very poor effect on, or it can have a very significant effect, which is usually a poor outcome for those patients. They, flush red skin, sweating, restlessness, just generally, to feel a high temperature touching their body, their chest and their head. Generally you can kind of feel it, but just to kind of get a ballpark. But nonetheless, we want to, really check their temperature with a good device. And sometimes they may need a rectal temperature, and it just depends on the age of the child and what the family has available. A lot of times they won't tolerate a mouth based thermometer. So if you can keep them still long enough, or they're old enough to do that, then that's fine. But again, a child's heart rate increases with each degree of temperature rise. So generally, if you have a fever, those vital signs are probably going to start to go up as well. Of course, it's important to open and maintain the airway, like we talk about for all our patients. Of course, you want to try to ventilate those adequately anytime they have a respiratory issue. A lot of times, like I said, these respiratory issues are what causes a cardiac arrest in our patients, and in these pediatric patients. They are, they don't have coronary artery disease or CHF or any of these other issues. Generally, I mean, there's sometimes you have some patients that are born with heart defects and all that sort of stuff, but it is generally not the case, right? They just haven't had long enough to develop these things. So a lot of times their cardiac arrest stems from a respiratory issue. So suffocation, aspiration of some type of foreign body, like I said, putting stuff in their mouth they shouldn't, choking on a hot dog or whatever, right? Infections of the airway, such as croup and epiglottitis, which we'll talk about, SIDS, sudden infant death syndrome, basically laying them on their stomach and having them suffocate or something along those lines. Accidental poisoning, so getting into the cabinet or the medicine cabinet and getting in some type of cleaner or medication overdose, something like that. And then, of course, injuries around the head or neck from them falling off of something, trying to climb up on something, trying to ride a bike, all those different types of things that they may experience. So like I said, a lot of times it is because of a respiratory issue from the beginning. Of course, we want to do the head, tilt, chin lift, like we said before. With those infant patients, we're going to do just the sniffing position. Unless we suspect a head or neck injury, then we'll do the jaw thrust. Again, we don't want to hyperextend these small children. We don't want to crank their head all the way back. Again, like I said, a slight sniffing position. That way we don't injure their neck. So again, CPR, just like we talked about, in CPR, it's essentially we're going to provide the same type of CPR that we would for an adult, except we're going to use either 2 fingers or one hand, and then we are going to usually do for infants, especially, we're going to do a little bit faster. So we're going to try to match that rapid heart rate that they already have and the rapid breathing rate, and we're going to try to give those compressions a little bit faster, right? So at least 100 times a minute. Again, we want to go just enough air to make the chest rise. That's for all of our patients. So just enough air to make the chest rise, especially when we're dealing with infants and small children, so that we don't damage their lungs. When we are suctioning, it's going to be, again, a careful type of procedure. We're not just going to jam it down in there. Again, make sure that you are looking inside the mouth, see if you see anything in there, and we can kind of rake it out. If not, if you're suctioning, try to suction just a foreign body out no longer than 15 seconds, and that may be all you need. But that's one of those things that we'll have to, like I said, just be careful when you're dealing with it, because as I said, is the potential for you to shove the foreign body farther into the airway is there. So just be careful at, maybe go into the side corner of the mouth and work your way down the side of the upper airway, and then try to, conduct your 15 seconds of suctioning that way. If it is a small child, and depending on what it is, if you want to use a bulb syringe, you could do that as well. Like we talked about, clearing the airway for the newly born infant, then that may be something we can do. But it's a lot of times you're going to end up using just a smaller standard suction device. So oral airways, we talked about that in adults. We could use those in kids too. They have very teeny tiny little bitty baby J tubes, oropharyngeal airways. So it's works the same way. Just be careful about putting the tip of that against the top of their mouth. For these small children, again, they have undeveloped palates, and the top of their mouth is very soft. So again, we're going to point it that way, but then we're just going to turn it and insert it and try to keep that tongue from flopping back. You don't see a lot of field use of the nasal airway for pediatrics. It's just not something that's done very much, but it's possible as long as it'll fit in there. They do make very small ones for them. Like I said, it's just one that you don't see very often. So partial airway obstruction, like I said, if they're an infant, then we may have to just do some 5 back blows, and just to see if it will come out, and it'll try to remove it on its own. For children, it would be the modified Heimlich. Essentially, we're just going to kind of take a knee, get behind them, and we'll use less force to try to do that. But nonetheless, we'll use the abdominal thrust to get those out. If you see it, again, we're gonna get it out. We'll do that until the object either comes out or they go unconscious. Once they go unconscious, again, we're going to start our CPR procedures, and essentially look in the mouth before we give our breaths, see if there's anything in there, and then we'll start our chest compressions and attempt our breathing as we would for normal CPR. Again, if you have O2, for partial airway obstruction, it's not necessarily a bad thing. And if you have a mask, if they'll tolerate the mask, try to put it over their mouth and their nose. You don't necessarily have to get an airtight seal. And again, if they won't tolerate that, then you may have to just hold it a couple inches away from their face and let it kind of blow by them. Complete airway obstruction. Again, same like we were talking before. The baby's usually is crying and talking, or just cry and make a bunch of noises, and now they're not doing that. You have the cyanosis. You have that they're kind of staring. Their eyes are big, right? So all those things kind of indicate that something's probably stuck in their airway. Of course, then because mom or whoever daycare worker, whoever may have found them like that. So they don't know if they did or not, but when they hand them to you, they're either wide-eyed and, kind of flailing around, or they are and cyanotic, or they are starting to look like they're about to go unconscious. And so one of those two things more than likely is going to indicate a complete blockage of the airway. So again, same thing. We're going to try that Heimlich maneuver for our children, and then for infants will be 5 back blows, 5 chest thrusts, 5 back blows, 5 chest thrusts until the object comes out or they go unconscious. However, and we talked about this in CPR with infants, you just have to be careful. I had to do it the other day. I thought I had to do it the other day. They weren't sure if they were choking or not, so I went ahead and did it. But it turns out the patient was having a seizure. It was like a 3-month-old, and just like I would normally do, put them in my arm, hold their face with my hand, and then do 5 back blows and flip them over, 5 chest thrusts, look in the mouth, see if I see anything. Did that a couple times, and then they started to actually have a seizure. And we realized that it was more than likely going to be a fever-induced seizure, so called a febrile seizure. And that's, that was just one of those things that we kind of had to get through the other stuff to make sure, just to kind of rule it out, make sure they weren't choking or aspirating on something. And once we did that, it was fine. But we kind of had a good idea what was going on with them. But nonetheless, it's it's scary to try to smacking on a small child right in the back. But again, a nice open palm, gentle pressure doesn't take a whole lot. to try to shake some of that stuff loose. And again, we're only talking about an airway that's probably 4 inches, 3 to 4 inches long. So just like that. Again, that's my preferred method of patient or infant patient assessment, is if I can hold on to them like that. So I'll put their legs on either side of my bicep and cradle them in my arm. I can really feel how hot they are. I can, look in their eyes. I can look in their mouth. I can, kind of manipulate what I'm doing with them a lot easier. Sometimes it is, if it's a smaller child, if it's a toddler and things like that, they really want mommy or daddy, and they want to hold on to them, and that's fine. That's common. So we're not going to try to rip them out of their parents' arms just so we can assess them. But if it's an infant like that, and mom is right there, then I just like to be able to hold them so I can get all those senses going at the same time, and do what I need to do. So of course you're going to ask first, hey, you mind if I hold the baby, and whatever. So that's always get permission before you just start taking them out of the mom's arms. You can get an irate mom real fast doing that. Swallowed objects, small round objects do not become airway obstructions. They usually pass uneventfully through the child. Sharp or straight objects are dangerous. So squares, little, Legos, that sort of stuff, anything like that, they're dangerous. And like I said, just kind of depends on if it's partial or complete blockage. If it's partial, let's load and go. We can just load and go and kind of get to the hospital, hopefully, and see what we can do. If it's complete, then we need to start doing something. They're probably not going to be moving air, so we need to try to take care of that as soon as we can. Just for your own knowledge, a paramedic is capable of doing an extraction of certain things to a certain depth of the airway. So they can take their laryngoscope, which is their little curved blade that they use to insert endotracheal tubes into the throat. And so they can take that, and they have a pair of long angled forceps, and they can reach down into the airway while they're visualizing it. They can lift open the airway and visualize it, and pull out. Usually they can pull out the foreign body, or at least move it to a location to where they can at least pass some air. So that's a worst case scenario. But again, that's just something that they can usually do. So respiratory distress, okay, so not arrest, but respiratory distress is breathing rate of more than 60 breaths per minute in infants, breathing rate of more than 30 to 40 in children, nasal flaring on each breath, retraction of the skin between the ribs and around the neck muscles, and stridor. So that stridor would be where their airway is starting to constrict, okay? And so it's kind of like breathing through a straw, right? You can't move as much air, and so it's going to make that kind of higher pitched sound. Cyanosis of the skin, altered mental status, combativeness or restlessness, again, are other signs of respiratory distress. The treatment of that, again, it just kind of depends on what the cause is, right? So, if they were in an oxygen deficient atmosphere, they didn't have enough oxygen where they were at, then, if we can get them some oxygen, maybe that'll clear up, what we need to clear up. But, so little things like that, it could be any number of things. Obviously, if they're choking on something, we'll relieve that choking, or leave the foreign body. So really want to try to determine what the cause of the distress is, and then we can start to work from there. Of course, trying to keep them calm, place them in a comfortable position, sitting down. A lot of times we don't want to lay them down. Just any respiratory distress patient doesn't like to be laid down. Typically they want to be sitting, and then at least sitting forward. So that's usually a good plan. So again, O2, if you have it, it's not necessarily a bad thing, especially as a general rule, it will help to calm them down. Again, depends on the age of the child. They may or may not tolerate a mask, so or definitely a nasal cannula. So they'll end up pulling it out anyway. So best thing is let them, if it's an infant, a lot of times you can let them hold the mask and they'll play with it at their face. They'll usually hold things in front of their face and play with it. And so children, they may just grab it and throw it down, but it's just one of those things where we may have to hold it near their face and let it blow by them and try to get them a little bit more supplemental oxygen to help saturate their system. Of course, we're going to try to monitor the child's vital signs just like we would an adult, heart rate, heart rate, blood pressure, respiratory rate, skin color and condition, temperature, that sort of thing. We're going to get all those things knocked out and try to build a good understanding of where we're at. And of course, we're going to transport them as soon as we can. So respiratory arrest or respiratory failure or arrest, again, where respiratory distress could easily become respiratory arrest, where there is no breathing cessation, right? So we also refer to this as apneic, right? So apnea, where they're not breathing at all, and or without respiration. So their breathing rate of fewer than 20 breaths per minute. Okay, breathing rate of fewer than 10 breaths per minute in a child. So again, this is the same thing with adults, right? If they may be breathing, but if they're not breathing at a rate that is where that'll sustain life, then that's not really, we're not doing anything. Okay, so if again fewer than 20 breaths per minute in an infant and fewer than 10 in a child, all right, we're going to start bagging and providing O2 and all that sort of stuff. Okay. The other one would be limp muscle tone. So if they have one of those and they're kind of going limp, they're more than likely, if they're at that stage, they're going to be very lethargic and not able to, carry on conversations and all that sort of stuff. So again, unresponsiveness, typically decreased or absent heart rate, weak or absent distal pulses. So again, we're starting to kind of backtrack here, as far as the patient goes. These patients are these children, pediatrics in general. They compensate for a while, and then when they get done compensating, they'll crash pretty quick. Okay, doesn't take long for them to cycle down and start to have some serious issues really fast. Okay, so it may take them a minute to get there, but once they get there, it's not good. So a child on respiratory failure is on the verge of experiencing respiratory and cardiac arrest. Okay, so again, very important thing to try to recognize. Go back and look at these signs and symptoms. Those different breathing rates. 20 in an infant, 10 in a child, and make sure you remember those and those signs and symptoms. So when you see those things, it's automatic. We're going to start doing some invasive stuff. So again, support the respirations best we can, whether that's mouth to mask or bag valve mask or whatever it might be. Any type of airway adjunct like our oral airways or nasal airways, whatever we might be able to do. Administer that O2 if we need to. We're going to start chest compressions. If the heart rate is less than 60 beats per minute, that's a pretty, good indication. We need to start doing those chest compressions. And then, of course, we're going to transport as soon as possible. And generally, like I said before, the most common cause of that cardiac arrest or circulatory failure is because of a respiratory failure. Okay, so that's ultimately going to lead to that. So if the heart rate is more than 60 beats per minute, you can go ahead and quickly complete the patient assessment sequence. Just try to get as much information as you can about the patient and what's going on. But you still want to support ventilations, administer oxygen, observe those vital signs. Again, less than 60 beats per minute, or if it's right there around it, it's a judgment call. If the patient, if everything else is going bad, respiratory is bad, and we're getting down to close to 60, if it's 65 and they're still, they look very sick and they're starting to deteriorate on the other side, the other systems, let's go ahead and just start our compressions and all that sort of stuff, and we'll give them a fighting chance. And again, we're going to have to do our normal CPR, rescue breathing, all that sort of stuff. So altered mental status, again, a lot of different reasons for that, but same with adults. Low blood glucose level, so children obviously can have hypoglycemia as well, and hyperglycemia. Poisoning, post-seizure state, so we call that a postictal state or post-seizure state, where they are really lethargic and just kind of out of it after a seizure. Infection, head trauma, decreased oxygen levels, all those different things are predecessors for an altered mental status. It's again part of that primary assessment to try to get to the bottom of why they're like that. Okay, or why does the family think? Why does the caregiver think that this might be an issue? All right, so we're going to complete that patient assessment as soon as we can and try to get down to the bottom of that. That way, it may kind of lead us down a certain road. Again, paying attention to the vital signs, get those early and often, and make sure we understand, where we're dealing with the patient at as far as, psychogenic shock or any of those types of things that might be affecting their, if it is some type of head injury or issue in the brain, and see how that's affecting the body, right? So be prepared to support the patient's ABCs if needed, and then place unconscious patients in a recovery position. So that way they're, if they do happen to vomit or, something along those lines, they'll be in a good position to do that. So respiratory illnesses like asthma, because some of these smaller children breathe through their nose a lot, colds and flus and things like that make breathing difficult sometimes. But it exacerbates all these other things as well. So all the stuff that we have as adults, they have as children, but because of some of these issues that they already have, makes it worse. They may not be able to clear their nose out like we blow our nose, and we clear out our nasal passages and all this other stuff. We can hawk up a loogie or whatever you want to call it, right? We get some phlegm out of our airway. They may not know they don't know how to do that. Okay, so they end up having to kind of work its way out naturally, or with medicine or something along those lines, and so it takes longer. They're more congested and all that. But as far as asthma, again, it's caused by a spasm or constriction in the smaller pathways of the lungs, and it causes a wheezing sound because, again, those small airways are constricted, right? So they're inflamed. Calm and reassure the parents and the child. A lot of times it's very stressful. They're going to be, sometimes they're going to be agitated because they can't catch their breath. Want to, again, try to keep them sitting up. Excuse me. Pursed lip breathing is like you see, you'll see here in this picture whenever it comes up. The children usually will, if you just tell them like they're going to whistle or blow, like they're going to pull through a straw, but tell them to keep their lips tight like that, and then and then blow out, and that will help to increase the internal lung pressures, just trying to get those breaths through there. You want to help by administering the child's medication if they have it. So if they do have an inhaler or something along those lines, we may want to do that, just to give them some relief. A lot of times they just need to shake it up and take a couple puffs of it, and they're usually pretty good. But so again, you may experience this at at a school or daycare or something along those lines. You get called for that, and you get there and they're having difficulty breathing. They say they have asthma, or the nurse or whoever's there on scene says they have asthma, and they may have already given them a dose. We want to know how much they've already given them. If they've already taken two puffs of their inhaler, is it albuterol or whatever it is, and that way we just kind of keep track of what they've already had. So another respiratory illness is croup, infection of the upper airway that occurs, but mainly in children between 6 months and 6 years of age. It's kind of results in more like a hoarse, swooping noise during inhalation, and a seal-like barking cough. So if they can't quite get it out, it's sounds like a pretty painful type exhalation on the cough part. So that's is never good, but often occurs in colder climates. So a lack of fright and willingness to lie down are important signs that distinguish croup from epiglottitis, which we'll talk about in a second. The EMS unit is delayed. Turn on the heater in the shower, and the hot water in the shower, and close the bathroom door. That warm, moist air will help to kind of relax the vocal cords and the throat. Again, just one little thing to do while you're waiting, if you're waiting on an EMS unit, but that might help them out. Also, if they have like a hot bowl of water or something along those lines, you can put a towel over their head and try to get some of that steam in their mouth. Just tell them to breathe normally, talk normally, and get some of that steam in their airway. Again, it's just one of those things that might help. It's not for everybody, but it might. Epiglottitis is severe inflammation of the epiglottis, so the little flap, right, that helps cover our airway to ensure that we don't get stuff down our lungs, right? So if that flap is so inflamed and swollen that the movement into the trachea is completely blocked, usually occurs in children between the ages of 6 months and 6 years, 3 and 6 years, and they generally, like I said, it's almost like you're choking, but you're never going to be able to get that up because it's attached, right? So it's it's definitely almost feels like you're choking, and it's something sitting in your throat. So the child is usually sitting upright when this happens. They can't swallow. Child is not coughing, drooling possibly. Again, they're not able to kind of like swallow stuff, right? So because of that, they're all that either mucus or saliva that's normally just kind of naturally swallowed isn't able to do that. So they may be drooling. So it's not necessarily for the baby, like baby drooling. It could be an older child as well. Child's anxious and frightened, and the child's chin is thrust forward. So they're trying to relieve pressure off of that. So again, that was the bigger difference there. The anxious and frightened part is not necessarily there with croup like it is with epiglottitis. Okay. So we try to make them as comfortable as we can with as little handling as possible. Keep everybody calm and administer oxygen. Arrange for prompt transport. It's one of those things that just kind of depends on how bad it is. If the when the EMS gets there, they may have to intubate them or intubate them a different way or something along those lines. Just kind of depends on how bad it is. So if they're still able to breathe, though, they can breathe through if it's easier for them to breathe through their nose or whatever it might be. But as long as they're able to pass air back and forth, that's the main thing. So working those ABCs, keeping those intact if possible. And we may have to, if they do happen to go unconscious because they're not able to breathe very much, it may relax that area a little bit and allow some air to go in. So we may end up having to bag them for a little bit, just to keep that airflow moving. So drowning, like I said, we're touching on a lot of different stuff here. So try to stay with me. Like I said, we're just going to keep moving on along to several different things, but drowning, again, is one of those things that we're really concerned about with small children. It's like the second most common cause of accidental death among children 5 years of age or younger in the United States. So, it's a pretty serious thing, and around pools and, especially during the summertime and all that sort of stuff, where kids are playing and they're outside doing stuff and drowning. And we think about pools and we think about, the creek or, something like that. But what you have to understand is, even like, especially smaller children, infants and things like that, and small toddlers, they're susceptible to drowning in the tub, in less than 2 inches of water. So, that's why we never want to leave children unattended in the bathtub. It's definitely something that could happen, where they just fall over and their face is in the water and they can't push themselves out of it. So it could be something as simple as that. So a puddle outside, if you have a small enough child, won't be able to get themselves out of that. So lack of breathing and no pulse, obviously, if you pull a child from the water, or somebody does, and you get there and they're not, big thing. We're obviously worried about the airway, so we want to see if they're breathing or if they have a pulse. If we can, we'll try to keep them in that recovery position. If it's an infant, we can try to have them in that face down position that we would for if we're giving back blows. And just help gravity, let some of that water flow out of them. And if we have suction, we can try to use that as well. Again, no breathing. We're going to start breathing for them, doing rescue breathing, 1 breath every 5 seconds, and CPR if necessary. Especially if they were without air for a little while, or oxygen for a little while, then we definitely want to give them some supplemental oxygen and stabilize the neck. That's just one of those general things where especially if we don't know what happened, how they ended up in the water, it's not a bad idea just to make sure that they didn't hit their head or neck while they entered the water. So hypothermia is obviously a risk at any time, whether it's hot or cold. So especially when they're wet. So try to get them out of their wet clothes and keep them warm, keep them covered up. And of course, we want to get them transported. Hunter, are you seeing heat-related illnesses on your slide? There we go.
Yep.
Okay, yeah, it just changed, I think. All right, so heat stroke is a serious and potentially fatal condition that requires rapid treatment. Heat stroke is the kind of the higher end, obviously, of the issues that we may have with heat, and it's definitely very easy to damage the brain when you have heat stroke, as well as several other body systems. So big thing, we want to try to remove their clothing, sponge water over the child and fan him or her. You can wrap the child in wet sheets to speed up the evaporation and cooling process. Generally, that heat stroke is, you're going to have some stages there of heat illness, and it's a lot of times you're going to have kind of that hot, sweaty, kid that's been outside playing all day, right? So that's the kind of thing that we're looking for with a mild case of heat exhaustion, would be something like that where they're really sweaty. Generally, when we get the heat stroke, if your patient is kind of clammy to the touch and has started to not sweat, has stopped sweating, that's generally one of the main signs and symptoms that we see whenever they start to transfer over into heat stroke. Okay, so the body is now compensating and it's trying to pull those things back into the core, and it's not working as well. All right. So high fever, I mentioned to you about this earlier. The fevers are just common in children. It's like I said, they put their fingers and hands in their mouth and their feet, and they pick up a lot of germs, and they get sick often, and all that sort of stuff. So they typically will have fevers of some type quite often. Most of the time, it's a children's Tylenol or a something along those lines, and they're good to go in an hour or two. Sometimes, especially with scared moms and that sort of thing, they'll end up in the ER, or they'll end up calling 911 for this, just as a precaution. But because the temperature regulating mechanism in young children has not fully developed, a high temperature can occur quickly. So, like we talked about early on, they're more susceptible to those types of issues. Most children can tolerate temperatures as high as 104. They might be able to tolerate it, but it's not good for anybody. Nonetheless, when you start to see upwards of 100 degrees, 102, 103, 4, 5, 6, those are not good for anybody. Okay. They definitely need to have some type of either medication or some type of cooling to assist them with that, because it's not going to be good for their brain if they sustain those type of temperatures. So again, uncover the body so the heat can escape. Don't put a hat on them or a beanie or something like that. Again, like I said, just kind of taking any warm clothing off of them, or clothing in general. Fan the child to cool them down. We don't want to put ice bags and all that sort of stuff. So it's kind of a gradual cooling type thing. And like I said, they do have the potential to have seizures, like I was telling you earlier about the child that I had to deal with. So they they could have those little moments of post seizure activity or the seizure activity where they're not breathing or holding their breath, and then that post seizure activity where they're a little lethargic and a little bit out of it, that sort of stuff. So we're always constantly monitoring them during this time to ensure that they that their ABCs are intact. For infants especially, same thing I was telling you. I was dealing with that baby. I could barely tell. It took me a second to where I tried to look at her eyes, and I couldn't physically open her eyelids. She was having such a strong seizure that, and she wasn't really contractured or anything like that, like an adult might be. But her arms were up above her head and kind of shaking a little bit, but it really was, the telltale sign was that her eyes wouldn't open. Her eyes were shut, and her fingers were clenched, so I couldn't even open her little hand. So that's that sort of stuff. You kind of look at it and go, yeah, that's, they're having a seizure. And then once they start to kind of relax and all that, then we're generally in that post-seizure state. So we just talked about all that. Seizures in general, the child's skin becomes pale or turns blue. So like I said, a lot of times, depending on how bad it is, they may have a loss of bladder control. it's not good, but if it is what it is. We'll just have to deal with that whenever we can. But um, it's just something to note, to say, hey, that's they had a seizure and they had that, so we want to convey that as well during our assessment. Like we mentioned before about seizures with adults, we want to keep them safe really from themselves. So put them on the floor or a bed somewhere where you can kind of manage them and kind of hang on to them. They may flop around or crawl around or do something like that, and so it's important to keep an eye on them so they don't hurt themselves. But the other part of that is maintaining an open airway, and then again just monitoring the ABCs throughout the event. So of course, afterwards, provide supplemental oxygen. Try to arrange for transport and monitor the ABCs, like I said. And after the seizure's over, try to cool them down. A lot of times they'll be kind of exhausted almost, especially if it's a small child. It won't take much for them to get exhausted having a serious seizure. So it's important to try to get them, keep them cool and keep them calm, that sort of thing. So if they wake up from a seizure and all of a sudden there's a bunch of strangers around, definitely having parents there, caregiver there to reassure them that everything's going to be okay. Vomiting and diarrhea. Definitely something that you'll see in pediatrics for different reasons. Like I said, a lot of times it really is because of the hands and the feet in their mouth and poor hygiene a lot of times. So when that happens, you end up getting little gastrointestinal infections and small little germs that are issues that or that cause issues with their stomach, and that manifests itself into vomiting and diarrhea. So because of that, it depending on the diet or daily intake of this child or infant, they could potentially be dehydrated, and so the child is usually lethargic and has dry skin. If they're dehydrated, it could take hospitalization to get them the fluids that they need and the amount of time they need them in. But it's it just kind of depends on what the issue is and what the parents want to do, whether or not they're going to take them to the hospital or they're going to have them transported. But always something to recommend, just to have them get some blood work done and see where they're at and see what they need. They may just need some fluid, and they'll probably be okay. Another thing, my belly hurts, right? So that's another fairly common one that you get, just child with stomach pain. And the most serious one would be appendicitis. Pretty common for kids and young adults to have appendix issues, and they generally have them removed. Seen in people between 10 and 25 years old, again, like I said, it's usually kind of cause you to be nauseated, no appetite. Occasionally you might vomit. Kind of treat every child with a sore or tender abdomen as an emergency. You want to treat it it says an emergency, and I think that's kind of a wrong word, but you want to give them due regard, right? So we're not saying that it's an emergency, like you need to run lights and sirens to the hospital for every child has a sore or tender abdomen. Sometimes the child just needs to go to the bathroom, right? So it's not necessarily an emergency in that sense. It's just one of those things where we need to, we need to do our full assessment, do our secondary, palpate the abdomen in all four quadrants, all that sort of stuff, and go from there. So that will be what you need to kind of help finish out your assessment, and so that you can understand a little bit more about what is actually going wrong with their abdomen. Of course, we're probably not going to be able to get to the bottom of that in the field. We're going to need to run some more tests and have x-rays and all that sort of stuff potentially, but nonetheless, if it persists, then we'll have to, we'll recommend that they go to the hospital. Poisoning by ingestion, again, ingested poison is taken by mouth. And again, like we talked about the other night with adults, it could be chemicals, could be anything like that. So you may have chemical burns, odors, stains around the mouth where they turned up a bleach bottle, or the degreaser bottle, or whatever it might be, right? So again, with that, generally you're going to have nausea, vomiting, abdominal pain, diarrhea, restlessness, anxiousness, could potentially be unconscious, also could cause seizures. So that's a little bit later stage, but nonetheless, things that we really need to be concerned about, especially in small children. It won't take that long for those effects to start taking place. Biggest things, like we talked about before, making sure that we know what it was, right? So we can find out, what that might be. It's definitely something that's going to help us determine how we're going to proceed. Definitely it will help the hospital how they're going to proceed. So if we can try to find out what that is early on, it'll make our treatment process go a lot more smoothly. So any spilled tablets, if it is medicine or anything like that, tablets or the bottle that it came in, or any of those types of things are going to be beneficial. The Poison Control Center, again, like I said, it's one of those things where we can do that while we're waiting. If we know what it is, while we're waiting on the ambulance, we can make that phone call, talk to the Poison Control, tell them what we got, and get some information, and get all that stuff jotted down. And then from there, we can, once we get a next higher level of care, we can, download them with all that information, and again, help them proceed with treatment a lot easier. So you may need to give the child large amounts of water or administer activated charcoal. Not usually going to be our call for that. As a first responder, it's just not something that you're going to do very often. Generally, I would refrain from giving them anything when we're not really sure, and especially when we're not sure what it might be. So definitely consult the EMS unit that's responding, and also the poison control before you give them anything. Of course, throughout that, depending on how long ago it was they took it, we're always going to be monitoring the child's breathing and pulse, just to make sure that they are, or their ABCs, just to make sure that they are still staying within those normal ranges. So absorption, again, has occurred when the poison substance enters the body through the skin. Localized symptoms, like skin irritation, burning, that sort of thing. So something got spilled on them, or they put their hands into something. That's usually what you'll see. Systemic signs are nausea, vomiting, dizziness, shock. Those first three are usually a little bit later stage. Takes it a minute for that to get into the bloodstream through the skin, and then they'll start to exhibit some of those as well as potentially shock. Big thing is, get them out of contact with the substance. We don't want them to linger in that, of course. And if we can get it off of them, that would be the best thing. So if it's brushing or copious amounts of water for at least 20 minutes, if we can get that off of their skin, that'd be best. If they have it on their clothing, try to, get their clothing off, decontaminate that. Again, copious amounts of water. And again, big thing, try to identify that poison, whatever that might be. However, while we're doing that, I know we're wearing our gloves and all that jazz and our masks these days, but make sure that you're keeping yourself safe from whatever that stuff is as well. So especially if it's an inhalation hazard or something along those lines, we don't want to inhale whatever they just inhaled. So try to get them out of that environment as soon as you can. So any changes they might be having, like I said, checking those ABCs throughout, just to make sure that they are there's no major changes there. If the child has vomited, whether it's for ingestion or absorption, they say save a sample and send it to the hospital with them. if you can do that, I mean, if it's going to be something you have to really work hard to get, and it's going to, take more time than it's worth, then not a huge deal. But again, if it's something where they can throw up into a bag or vomit into a bag, then, not a big deal. You can go ahead and save that in a biohazard bag, tie a knot in it, and bring it to the hospital with them. So sudden infant death syndrome, or SIDS, like I said, I've worked one of these before several years ago. Never easy, typically in an infant, very young, young infants between 3 weeks and 7 months. So anytime a child like that, is, you experience something like this with that age of a child, it's very, very difficult for everybody involved. So, you will end up, and like I said, there were things that I did on that call where I wouldn't normally do. I mean, I walked in the door. They literally said the baby's laying right there. I picked up the baby, turned around, walked out the door, and as soon as I walked out of the door, the ambulance was pulling up, and I literally opened the back door of the ambulance, jumped in the back door of the ambulance, and the paramedic and the basic came to the back door of the ambulance and looked at me like I was crazy. And I told the paramedic to get in, and I told the driver to drive. And they realized real quick that I knew what I was talking about, and they did those things, and we screamed on down to Piggy into the hospital. Baby ended up dying, but nonetheless, it was it's a pretty chaotic type situation. So again, it's sudden and unexpected, especially. That's one of the big things. No adequate scientific explanation really for SIDS. A lot of realistically, it's more likely going to be suffocation for the most part. Could be carbon monoxide buildup due to lack of oxygen. Because of that suffocation type thing. So there's, generally they're face down, something along those lines. They also don't recommend these big bulky blankets and stuff for infants like that, just because they can get wrapped up in them and can't get their face out of it. Like I said, I mean, it just kind of depends on what stage it's in. If it's all night long, if they've been there all night long, then obviously it's more than likely going to be one of those things where we may not work them from an ACLS standpoint, but it just kind of depends. It's going to be a judgment call for the people who transport. And but nonetheless, if we're first on scene, no pulse, no breathing, and we don't have any of those morbid signs, so if they're not rigid and they don't have lividity and all that sort of stuff, then we can try to work them. But if they have some of those signs, it may not be good. You will see EMS crews that will take the baby, put them in the back of the ambulance, and work them out the door. And they'll say that they're working them, but they're really kind of just doing it for show, as some type of closure for the family to say that everything was done. But in reality, usually the paramedic will know that they're deceased. So kind of depends on the situation and things like that. But nonetheless, we want to be very compassionate with the parents and try to be upfront with them and let them know that what we're doing and why we're doing it and all that sort of stuff. So we just talked about lividity a little bit and all that sort of thing. So again, if the baby is dead, if they have those large bruise-like blotches on the body, especially on the, could be on the front, because if they are face down, then that blood's going to pull more towards the front than the back. So you may have those blotches more on the front that could look like some type of abuse or something like that. But again, caused by the pooling of the blood after death. So one of those things, just if you have local protocols or management from your department or something like that of how you deal with deceased patients, then just follow those protocols and you'll be good. All right, we'll take a break right there. We'll pick it back up with pediatric trauma in about 10 minutes. So take 10.
Hey, Justin, you mind if I add something to the SIDS thing?
Yes.
Just while I mean, they could still be on a break because this will be in the recording.
No, I'm kidding. Go
But
Oh, he's got a problem with it.
it's all right. I'll rank them.
Go ahead.
So as EMRs, like he was saying, SIDS typically is a respiratory issue that goes out of control. What we don't understand is not how they're dying. We don't understand is why their respiratory system is closing down. So you as an EMR, bottom line, if you show up to a call and it looks like this is what you're going to be dealing with, grab the ambu bag and be aggressive and get them some air. Start ventilating for them. I don't mean do it in the way that you're going to pop their lungs, but don't sit back and be like, well, I don't know what to do. The reason that they're going into cardiac arrest is because for whatever reason, their respiratory drive shut down. So if you can get them ventilated fast enough, you may save the pulse and they won't technically go into cardiac arrest. And then that buys the hospital time to figure out what's going on. It's a long shot, but it is something that you can do. So the minute you think SIDS is an issue, whether it came across dispatch or if that's what your assessment shows you, the first thing you should be grabbing is the BVM. That's all I wanted to say there. Yeah, Justin very thorough with SIDS, but just as far as what you do on the scene, start bagging.
Yeah, absolutely, Rob. That's that's definitely really one of the main things we're really going to be able to do is just support those ABCs and make sure that they that we give them a fighting chance, and because like I said, we just a lot of times you're just not going to know how long they've been down, and generally they're going to be a very distraught, chaotic scene. So the quicker you can start working that issue, and that's the great thing about having a patient that size that you can throw them on your arm and walk right out the door. So tell mom and dad, hey, follow me. We're going to the ambulance. And as soon as the ambulance gets there, jump in the back of the ambulance and let's go. There is no reason for you to sit there on scene whatsoever. Everything that you can do for that child, you can do in the back of the ambulance. And so they can pull out the Broslow tape and do whatever they need to do and give them a fighting chance where that, and start those ACLS protocols. All right, everybody, we'll get back to it. So going into pediatric trauma, again, some similarities, but also some differences here. You know, like I said before, children just at different ages for different reasons have have a very high susceptibility to traumatic issues. Like again, falling off the bike, crawling up on the cabinet, pulling the hot pot off the stove. All these different things make them susceptible, as well as their anatomy issues, their respiratory issues, and all those different things as well help to exacerbate that. So, we try to treat them as we would an adult, but there's still things that we need to look for, and some of those things are obviously, we talked about it earlier with them, the communication issues. So we want to assess them in that way, but at the same time, we have to come to grips with the fact that they may not be able to answer our questions depending on their age or their injury. So we are still the same way. We're going to look for those injuries, DCAT, BTLS, and all those sorts of things are going to be looked at as well. But if we have a child that's shy or overwhelmed by all these adults and people they don't know and all this other stuff, they may be reclusive and standoffish and guarded and all that. So the easier you can make it for them, the more comfortable you can make them, the better generally your outcome is going to be. So you may need to adapt the materials and equipment to this child's size. So if you have some type of, if you have child or infant type materials, so C-collars or adjuncts or whatever it might be, that'd be the best. But if not, we may have to try to adapt some of the things that we already have. I mentioned it earlier, but again, a child does not show signs of shock as early as an adult, but it can progress into severe shock quickly, right? So they compensate and then they'll decompensate very quickly. So it takes them a little bit of time, but when it happens, it'll happen quickly. So talking about patterns of injury, like I said, just because of their stature and the type of trauma and activity they were doing, that it makes it to where you run into certain injury types and patterns that are more synonymous with a child. So unrestrained patients have more head and neck injuries. Again, just because they may not be ready for it, right? They're not consciously looking at the road, looking for hazards. They're looking for the punch bug or the floppy thing with the air in it that's over by the car dealership. You know what I'm saying? They're not worried about what's going on the road, and so they're not expecting it. And generally restrained or restrained, they'll still have some of these more significant injuries because their anatomy is not as prepared as ours, for one. So again, those restrained patients may suffer head, spinal, and abdominal injuries because of the seat belts, airbags, that sort of thing. Still will have some type of potential there for injury. May be less severe than if they didn't have those things, but nonetheless, it can still have some internal injuries and abdominal issues, things like that because of the seatbelt. Bicycle accidents, again, we mentioned this a couple times already. It's definitely something that you see with different types of toys or bicycles. So we could kind of lump this into a lot of different things. So this could be skateboards, rollerblades, bicycles, powered, power wheels, type, battery powered type vehicles and that sort of stuff. They have some really young kids. 5, 6, 7 years old, on motorcycles, four-wheelers, all sorts of stuff, right? So all these things can kind of apply to it. But again, the use of helmets, greatly reduces the number and severity of head injuries, but you often don't see that. There'll be parents who put helmets on their kids to go ride the bike, but they won't put it on their child to go ride the four-wheeler. So we live in an area of the world that really gravitates towards ATVs. Just in our area here, we have a lot of people that ride ATVs and that have grown up on ATVs and that sort of thing. I can tell you emphatically that over the last year, especially during COVID, we have had numerous very serious ATV accidents involving children. Some of them have resulted in death. At least 3 of them have resulted in death. Others have resulted in serious head injuries that have taken months and months to rehabilitate from. It's, I've seen, large lacerations, partial amputations, all sorts of stuff. So, right here in this county, in our area, and just within the last year. Again, one of those things that we really have to be cognizant of and looking out for. So this is another one. When we talk about injury patterns, so like with adults, when we have vehicle versus pedestrian and an adult, generally we have lower leg injuries, maybe a head injury, stuff like that. But in the child, we see this multi-system trauma because generally these vehicles will hit all of that. So they'll get the legs, they'll get the chest, the head, in no certain order. So, we had one yesterday, vehicle versus 12-year-old on a skateboard. So, luckily he didn't have any major trauma, but he did have road rash on his back. He had lacerations on his elbows. His face was also had some lacerations on it. The windshield of the vehicle on the passenger side had a small spider webbing, indention there. I'm not sure exactly where that came from. Maybe an elbow. I don't think it was his head, just because the way his LOC was, he was pretty good for taking a windshield to the head, if that was the case. But more than likely, some other type of part of his body or whatever hit the windshield and caused it to crack. But nonetheless, these things happen all the time, and so knowing that, knowing what we're looking at here helps you to kind of set up and get the full understanding of what that mechanism of injury is. And that way we can start to kind of identify areas that we need to be concerned with, whether it's a head injury or, a chest or legs or something like that. Again, falls from height or diving accidents, cause a number of these issues as well. It's one of those issues that we look at from the standpoint of, yes, they only fell from 4 feet off the counter, but how big are they, right? How much, I mean, for us, if we fell 4 feet, wouldn't be a big deal, right? But if they are only 4 feet tall, then that's going to be pretty significant for them, right? So just like if we were to fall from 6 feet. Burns are also a major cause of injuries to children. They, again, could be immersion burns, could be burns from, like I said, from them pulling things down on top of them, grabbing hot things. So a lot of times it's on the extremities that we see these burns. Sports injuries are another big one. Just children wanting to play sports. I mean, it's most all of us have done that at some point in time, whether it's baseball, football, basketball, soccer, archery, whatever. We run into all those different varying degrees of injuries. And so, I was in sports medicine for a long time. I've seen, hundreds and hundreds of injuries varying from, dislocated thumbs and fingers to, dislocated shoulders and all that sort of musculoskeletal stuff to, complete, open fractures of the ankles and the elbow and stuff like that. Just playing no contact sports like baseball, softball, basketball. So it's definitely something that could happen in any number of sports out there. So again, we find it, we fix it. We're going to do that full body assessment, and then whenever we find those things, we'll fix them. And of course, we're going to worry about our ABCs as our primary concern. And then, of course, as we go through our LOCs, checks, and all that, we're looking for any issues with their head. So if they did happen to get injured somehow, how did that happen, and was their head involved? Traumatic shock in children, again, if we have that multi-system trauma, especially, we run a greater risk of having some or multiple forms of shock. Again, that children show shock symptoms much more slowly than we do, but the progress through the stages of shock quickly. Okay, so if you remember that, that's one of those things we've kind of hit that home 3 or 4 times, and that's just one of the big differences. We talked about that earlier, that there were going to be differences in children, and that's one of the big ones, especially as it relates to multi-system trauma and shock and all that. It's definitely something that sets them apart. So signs of shock are present. The child is already in severe shock, right? So that's kind of what we're getting at. So if you see some of these signs of shock, just understand that we're already behind the curve, okay? And so we definitely need to do the right things quickly. So cool, clammy skin, rapid weak pulse, rapid or shallow respirations. Those are some good indications. Seizures are relatively common in children who have sustained a serious head injury. Again, unfortunately, I've seen this multiple times in the last few months with some of these ATV accidents. They've been head injury predominantly, and we've had this happen a couple times. Even posturing, deliberate posturing in one of them. But again, as bad as that is, remember that airway obstruction or hemorrhage is one of those great dangers when it comes to that. So we want to keep the blood inside, and we want to keep that air moving around and around. Okay, so we want to, and a lot of times it just depends on where you're at. So for those of you who are predominantly running calls out in the county and those types of places, don't be afraid to call for that helicopter, or call for multiple units, something like that, so that paramedic that paramedic has some help coming with him as well. They have done that before. Well, they'll send 2 units for one patient if they have them available. That paramedic will ride in with that other paramedic, and they will do a lot of other invasive things along the way. And the other ambulance will just meet them at the hospital, pick their paramedic up, and they'll be free to take calls. But if it requires that team effort, then they'll do that. Same way with the helicopter. If the helicopter will come down, the nurse or the paramedic can jump off, get in the ambulance, go with them by ground if they need to the hospital, and help them on the way. So if that's something where they can intersect in a reasonable amount of time and not be waiting or dragging their feet trying to get to the hospital, that's also something they can do. Or they can maybe potentially take the patient and fly them there as well. Car seats in children. Again, we have a lot of different versions of car seats these days. So we have booster seats and car seats, and seats that pop out and you carry them around, especially for the infants and small children. So a lot of different versions out there. Behoove you, if you don't have kids or never had to work with a car seat, to put your hands on a few different types, and just to have an understanding of how they work and how they disconnect and connect, and that sort of thing, how the child goes in there. You see them here kind of holding manual C-spine of the child. Easier said than done, depending on the child's attitude, right? But it's definitely something we try to do if we have the mechanism of injury that would lead us to believe that they have some type of head or neck injury. But ultimately, if you find a child that's properly restrained in a car seat after a crash, best thing is just leave them in the seat. There's really no reason for us to take them out and bounce them around and move them around, all this sort of stuff. If they're in there and they're okay, leave them in there. And you'll get that sometimes where mom wants to just hold the child close to her, or parents in general want to hold their child close to them. It's you can tell them, hey, ma'am, if you don't mind, just leave them in there. They're better off if you just leave them in the car seat. And you may get a dirty look and a hand gesture or something, but it's worth a shot. You can ask them, and if they may just say no, and they'll pick them up and hold them anyway. But that's up to them. So a lot of times, if they're in the car seat, they can be transported like that too. So we'll just put them in the car seat, put them in the jump seat, and in the ambulance, strap them into the jump seat, and they're good to go, and they ride like that. So especially if mom's injured too, or the family or parents or whoever is injured too, then they'll ride on the stretcher, and the child will ride in the jump seat, and they'll be good to go. Child abuse. This is something that you may encounter from time to time, and it's a touchy subject, and you kind of have to be a little bit. You have to be professional, and you don't want to. You kind of want to tiptoe around it. You don't want to really be so obvious about it. If you notice these things, but at the same time, you want to be quick to tell somebody about it, so that for one, you don't have any liability in it, and two, that the child gets the correct care that it's due. So again, be concerned if they are fearful, they're hostile, unwilling to discuss how the injuries occurred. If they seem like they've been coached, these are other signs. So treat the injuries, and if you suspect abuse, ensure the child's safety. And like I said, we're not going to physically take them away from their parents just because we see some bruises or burns or something like that, right? We're not just going to, try to take the law into our own hands. But, if you feel like it's significant and you don't want, really don't feel safe with the child, leaving there with somebody other than the ambulance, then, call for law enforcement. Have them come by, talk to them, tell them what you see, and let them start working it from their angle. And if not, run it up your chain of command as well, probably at the same time. Let somebody else know. Let the hospital staff, if they are going to be transported to the hospital, let them know. Of course, the next level of care, where it's a paramedic or EMS crew, somebody that responds, definitely let them know in a discreet way, right? So maybe meet them at the ambulance, have a little chit chat with them before they get inside, and let them know what you see. Multiple fractures, bruises, and various stages of healing. So old ones, new ones, human bites, burns, bizarre accidents, things that may have happened around the house, not necessarily playing type accidents, but that, that may constitute that. So again, we don't want to, usually if you bring that sort of thing up, even suggesting it as a question, in a professional manner, generally it's going to get taken offense to, and you're going to start to make things a little bit more hostile. So best thing is to, if you can ask once, hey, how'd they get these bruises or whatever, take whatever answer you're given and jot that down, and then you can include those types of things in your report. But it's important that you worry about treating the patient, and then, like I said, run that stuff up your chain of command and through law enforcement. So any number of things could be burns. Like I said, it could be immersion burns where they've been subjected to hot water, bites and bruises, So, and again, you get some of these children who, toddlers even, and some of these middle of the age range of children who, around here especially, they will go run off into the woods and, jump off the house and, all do all sorts of stuff, whatever, on their own. But when they come back in at night, they look like they've been into a mud fight. They've been beat up. They've been stung by everything. They're bleeding, and so mom and dad had nothing to do with it, so, definitely stuff to note, but also to understand, what they were doing, how it happened, that sort of stuff. Again, if you have to, if they're wanting to transport, then, if the parents object to that transport, and it's warranted, it's needed, it's potential that you have to get law enforcement involved to ensure that that patient is seeing some type of care. Again, signs and symptoms: lack of adult supervision, malnourishment. So that could be another part of it, is that the parents aren't around. The parents, the parents aren't even there when you see the child. It may be, the 12-year-old brother or sister or cousin or whoever. It's the friend's child, the mom's friend. It's their child, and he's, that child's watching this child, and, or that there's nobody there with them, right? So we've had all of the above. Just unsafe living conditions. So if you get there and it's just a very, very bad, the child is essentially sleeping on the floor with the dog, and, that sort of stuff. And it's just very nasty, and there's feces everywhere, and the child's obviously has, a soiled diaper and has obviously been in that diaper for quite some time. They have rashes all around the genitals and stuff like that. That also would be a concern for law enforcement. So again, in addition to experiencing sexual assault, the child may also have injuries, may have been beaten, and may have other serious injuries. So again, sexual assault is definitely one of those that we have seen before as well. Again, some of those that'll be very standoffish, probably not too quick to tell you, why their private area is hurting, or something like that. The fact that somebody even calls would be probably because somebody else found it. So, grandma got the kids for the weekend, and then the child told them that their private area is hurting, or that, Uncle Jimmy, hurt me in my private area, right? Stuff like that. And so generally that's how you'll receive those calls. But again, try to approach it as modestly as you can, with a level of concern and care that you would for your own children. With probably not quite as much hostility. So again, same thing, try to treat it very professionally, treat the patient, and then notify the appropriate authorities as well. And then generally, we don't want any sexual assault victims of any age. We don't want them to change their clothes. We don't want to cut their clothes or remove any of that we don't want to remove any of those types of things, and definitely let law enforcement know immediately. So talking about debriefings, we mentioned this before with traumatic situations where we may need to be concerned about our mental health. And this is definitely one of those where we encounter when we encounter children of any age. It can be very emotional. Like I mentioned to you before, we've had responders that do a lot of crazy stuff, a lot of inappropriate things, driving way too fast, recklessly, endangering themselves and the public, trying to get to a call for a multiple vehicle accident with involving a child, and they will just drive the ambulance or the fire truck or police car or something so fast that they can't manage traffic, and putting a lot of people's life in danger. And so any of these types of events that are so taxing like that, it's always good to talk to somebody about the event. We've had some not that long ago that involved some children. It was a very horrific accident. There were several people that died, including children, and they were mortally wounded. So they had some very serious avulsions and eviscerations and all sorts of stuff like that. And so just that, especially, in a morbid type way, is challenging. So when you see a child that's ripped open or decapitated or things like that, it's very disturbing. So disturbing enough for an adult, as dealing with adults, but even more so with children. So again, you may experience a lot of those different types of stressors, and it's one of those things that you just need to try to feel out your peers, your coworkers, let them know how you feel and how it made you feel. You guys talk about the call and how it went down and things that you can do better. And, you work through that way. And generally that's a great way to start. If for some reason it lingers, it goes past, a week or so of dealing with that, start, bring it up to your chain of command and start working on talking to somebody that has a little bit more understanding of this type of stuff. And then you potentially may need to talk to an actual professional about it and see what they have to say. Again, loss of sleep, loss of appetite, anger issues, disconnection at work and school and home are all signs and symptoms of these types of things. But I can't stress that enough. After the after call briefing, put everybody around in a circle and just say, hey, how do you feel? What's going on? Everybody okay? Any injuries? Maybe a quick little 5-minute thing, or we get back to the station, or we get back to, we get done with the call, and maybe we have a little bit longer of a talk about something. Or if you don't feel comfortable doing that, pull your supervisor off to the side and go, hey, listen, I'm not feeling, I'm still kind of sick to my stomach. I don't feel well. I'm having images, all these different types of things, and, let them help you work through that. Talk to them about why you feel that way. But definitely talk to somebody and work on getting some help early. We mentioned about mental first aid, right? We talked about that before. It's definitely the way that we need to approach that, is that we can, we're not going to put a Band-Aid on a big knife wound, right? We are, we need to apply the appropriate type of treatment and bandage to that big wound, if it deserves it. So, don't be afraid to do that. Don't be so prideful. Don't be so type A, or have that air about you that you feel like you can't express your feelings. Okay, because I'm telling you right now, it will be very damaging in the long run if you don't treat it early on. Okay, it just makes it worse. So, anybody have any questions for me on tonight? Sorry again about the late start. We had a pretty busy afternoon in the county. So, but nonetheless, this is our. See, it's just chapter 17. We have chapter 18 and 21 coming up, and those are the last two, right? So the last two classes before we start talking about our boot camp. So again, if you haven't done your quiz, you haven't caught up on your quizzes, you have got to do that. You need to catch up on your quizzes, and again, work through these chapters. And again, we're right here at the end, so we're not going to taper off. Okay, we need to keep up with all your stuff and push on to the end, and we'll work through that. So any questions from tonight or anything else? No. All right. The core of the class code for tonight is going to be R0013. R0013. Rob, you got anything for him?
No, I'm good.
Okay. So again, next Tuesday, we'll be doing chapter 18, which is geriatrics. Okay, talking about old people. All right, y'all have a good night.
Hey Rob, can you I'm finna send you an email about some information that I need to get from you.